Hi, everybody. I'm Dr. Cindy Mosbrucker, and this is part 2 of adolescent endometriosis. And let me share my screen. Here we go. Part 2 of adolescent endometriosis. And now we pretty much talked about the disease and the prevalence and what it looks like and the symptoms in part 1. Now we're going to talk about pain processing and why teens sometimes feel the disease more significantly than adults. So there's this guy, his name is Lorimer Moseley, and he's a PhD neuroscience guy from Australia. He has written a book that's online. You can download it and read it in about 15 minutes called Explain Pain. And it's really good at explaining why we feel what we do and why our perception of pain is the way that it is. And I first became aware of him about 10, 11 years ago at an IPPS meeting. IPPS is the International Pelvic Pain Society. And he was doing a long, involved, basically a half-day lecture on pain processing. And it was the first time that I'd ever heard anybody talk about pain in this way. We were not taught this in medical school. And to my knowledge, most medical schools, even now, don't really teach a whole lot about pain processing. So let's talk about some definitions first. Nociception is pain before it becomes pain. So basically, pain isn't pain until the brain processes it. Nociception is the sensory signal that travels from the sensory neuron through the nerves up to the spinal cord, and then through the spinal cord up to the brain. It goes into the thalamus, which is where pain signals are processed. And I should say that prior to seeing Lorimer Moseley and hearing about this stuff, I had been struggling to try to understand why some of our patients had horrible disease and hardly any pain, and others had very little disease but horrible pain. And it just didn't make sense to me why there was this disconnect. And once I heard this lecture, it all kind of made sense to me, and then started reading afterwards. So here's a picture of the brain, and we're going to talk about a little bit of neuroanatomy. So this is the thalamus here. The thalamus is the relay center where all of these things are processed. The signals coming up from the spinal cord come through the thalamus, and then the thalamus reaches out to the sensory cortexes to see what's going on. E here is the limbic system, and the limbic system controls emotion. So when a nociceptive signal comes up the spinal cord and gets to the thalamus, essentially what happens is that the thalamus reaches out to the sensory cortexes, to the visual cortex, and says, hey, are we seeing anything dangerous? Auditory cortex, are we hearing anything dangerous? Are we smelling anything? Are we feeling anything that is dangerous? And if the answer is no, everything's fine, then the thalamus activates what's called the descending inhibitory pathway of the spinal cord to basically shut down these signals and make them go away. However, if there really is something, if it's a rattlesnake, if it's a hot stove and we're burned, things like that, then the pain perception is heightened because we need to do something about it because we really are truly in danger. And so sometimes, though, the sensory cortexes will say, no, we're not seeing anything. We're not hearing anything dangerous, but we're anxious and we're scared. And we're like, but maybe something is wrong. So this brings in the variability of pain processing and the influence of psychological and psychosocial factors on nervous system processing. And here in the picture, you can see this guy and his pain experience is being influenced by prior experiences, by his mood, by anxiety, by depression, by his genetics, and by the biochemistry of his brain, as well as how sensitized things are. So let's talk about genetics for a minute. Everybody is born with this internal thermostat that cannot be reset. And the thermostat basically sets the sensitivity for pain perception. And you take 10 different people and you take a hammer and you hit their thumbnail with a hammer. One's going to go to the hospital to get pain meds. One or two are going to be like, yeah, whatever. And a lot of them, me included, will be like, oh, that hurts. But they'll go to the freezer and get some ice. And 5 minutes later, they'll be just fine. And so I've had how you were born and what your genetics are has a big role to play in your preset pain perception threshold. And I've had patients, young patients who come in with their mother. And this one lady told me a story. She's like, yeah, this one, when she was little, she'd fall down and skin her knee and she'd cry for an hour. And her sister would do the same thing and she'd just keep running and keep playing. And it's like, boy, doesn't that illustrate this point that two kids can grow up in the same household with the same influences, and yet they have completely different pain sensing thresholds. One is super sensitive and one is really not. So there are other factors that influence this sensitivity. And one of the biggest ones is childhood trauma. And, you know, whether it's your house burns down when you're 5 years old, whether it's, you know, a car wreck, one of your parents dies, or probably the worst is any kind of sexual trauma, especially for women with pelvic pain. All of these things increase our sensitivity to how much pain we feel for any given stimulus. So these influences cause something called central sensitization, which is where the brain perceives pain as being more painful than it actually should be, or that how most people would feel it. So central sensitization is increased by trauma, stress, obesity, depression, and anxiety. And in patients with fibromyalgia, which I think most people given a diagnosis of fibromyalgia, they just have central sensitization. Fibromyalgia is not really a disease. But they've studied them and they've done pressure testing. So basically they take their arm and they push on it with a certain amount of force per square inch. And what they find is that people that have fibromyalgia or central sensitization, a stimulus that for most normal people, they feel is pressure and maybe it's a little bit uncomfortable. People who are centrally sensitized perceive that as being painful. And so that's kind of how central sensitization works. There's also a thing called pain catastrophizing, which is I have pain, therefore I can't do this and this and this, and then my life is over. And these cartoons are really kind of funny, except that the idea of pain catastrophizing in real life is really not funny. This one on the right, the guy sitting in the easy chair, thinking that all of a sudden his life is going to be over, and he's in a wheelchair, and his wife and his family and even his dog doesn't want to have anything to do with them. I think could be rewritten to be a young girl who is afraid of the lack of fertility, the lack of intimate relationships, and the lack of basically a normal life in the future. And basically what pain catastrophizing is where someone magnifies the expectation of future pain. It's also related to the fear of future pain as well as failure. Like I said, in relationships, or, failure to have a family, things like this. It's also a sense of helplessness. And so this slide depicts a study looking at pain catastrophizing in adolescent girls. And they took 84 girls aged 10 to 17. Half of them were enrolled in a chronic pain clinic. And their pain was anything. It was orthopedic, headaches, and GI kind of stuff, more so than it was pelvic pain. But then they looked at that group compared with a group of normal girls who had no pain, who were the same age. And they administered these standardized questionnaires to try to figure out if they had pain catastrophizing. And what they found was that the girls, mostly in the chronic pain group, who catastrophized had far worse pain from their menstrual periods, even though they weren't going to see the pain management docs for any gynecological problems. And so this tells us that pain is elevated because we are afraid of it. Pain is heightened. We feel it worse because we're worried about what's going to happen tomorrow and the next day and the rest of our lives, because we think that the end of the world is coming. This is another study looking at coping mechanisms, and coping strategies are interesting to talk about in teenagers because I don't know if any of you took psychology in college, but one of the big pillars of modern psychology is Erikson's stages of psychosocial development. And basically what he contends is that when you're less than 1 year old, you have to attach to your mother, and then, as an early toddler, and then a school age kids, there's different things, different landmarks that they have to achieve in order to develop a normal personality. In teenagers, it's identity versus role confusion, which role confusion is basically an identity crisis that causes anxiety. So the psychological job or duty or thing that teenagers need to do in order to develop a normal personality is they need to develop a sense of self, a sense of independence and control. Well, how can you do that when you have endometriosis and you have pain for a quarter of the time, right? 1 week out of the month, some of them have pain for 2 weeks out of the month. And so this significantly inhibits their ability to develop that sense of independence and control in their own life. So this is a study that looked at the impact of coping strategies on quality of life in adolescents, and it was done in teenagers and girls less than 25 with endometriosis in Puerto Rico. And 79% of them had mild anxiety, 46% had moderate to severe anxiety, 54% had mild depression, and 35% had moderate to severe depression. half of them over here had significant limitations on a lot of normal things that we take for granted. Work, walking, pain controls my life, it controls my mood. People don't understand me. And so this is an inventory in quality of life that they administered. And then they tried to study what coping mechanisms these girls used. And I'm not gonna, because I can't really, I'm not a social scientist, but I'm not gonna explain what all these numbers mean, except to say that autocriticism, being down on yourself, feeling like I can't do anything, I'm no good, I suck, my life sucks, my situation sucks. Autocriticism was the worst coping mechanism, followed by lack of emotional expression and lack of social support. So these things were felt to be maladaptive coping strategies. And the one that was most beneficial was cognitive restructuring, with the biggest change seen in the right direction, which for this is negative, but it's really positive. So what is cognitive restructuring? Well, cognitive restructuring is a process where one learns to identify maladaptive thoughts, known as cognitive distortions, all or none thinking, magical thinking, magnification, and other things. So basically, magnification is pain catastrophizing. And so cognitive restructuring is basically a process of learning how to be resilient. So let's talk about resiliency, because resiliency is really the opposite of pain catastrophizing. And this is a really, really, really good study. It's not really, it's a paper that summarizes other studies. And for those of you who have teenagers that you're trying to understand them, or for those of you who are teenagers and you're trying to understand yourself, it's a very good read. It's easy to understand. It doesn't have, excuse me, a ton of medical lingo that you need a dictionary for. And it's a free online paper. And so they talk about resilience as the maintenance of a positive physical and emotional functioning in spite of significant difficulty or a challenge. And it's kind of the opposite of vulnerability, which is factors that contribute to worsen physical and psychological functioning in response to stress. So optimism is one part of resilience, as is hope and pain acceptance. And vulnerabilities are basically anxiety, depression, and pain catastrophizing. And if you kind of look at it in this picture, there's whatever causes the pain. Their analogy is arthritis, but it certainly could be endometriosis. And the pain is perceived in the brain. It gets to the thalamus. The thalamus reaches out and says, hey, what's going on? And the memory says, we're on our period. And then the emotional part of the brain in the limbic system wants to intervene, and the vulnerability mechanisms such as catastrophizing, negative social interactions, negative affect, which is basically emotion, or is anxiety, depression, things like that, are going to try to influence the pain. On the flip side, these resilience mechanisms, having a positive affect, having positive social interactions, and hope for the future, are also going to affect how the pain is perceived. And so these two things are basically fighting to help to determine, is the pain increased or is it decreased? And resilience is basically a cognitive thing where it has to do with positive coping mechanisms and good coping mechanisms, whereas vulnerability is more of an emotional thing. It's anxiety, depression, and catastrophizing. And so the point of this paper was that you can learn resilience. There's a lot of cognitive behavioral therapy things online that can help to teach resilience. And I think it's a very important thing, especially in kids, because their coping mechanisms haven't really been developed yet. They don't have a lot of life experiences. They haven't learned that, yes, I can hurt, but it's not going to kill me. You know, most people, by the time they get to my age, they have messed up their knees and torn cartilage and torn rotator cuffs and arthritis and this, that, and the other thing. And everything hurts at one time or another. And it's, you know, there's always something that bothers us once you get to mid 50s and 60 and things like that. And, but we've lived our lives and we've have enough time and enough life experiences to realize that, yeah, this isn't going to kill me. It's not going to stop me from going skiing. It's not going to stop me from going to the gym and working out. I have to, in fact, I have to do those things despite my pain, because these are the things that make me feel better. And teenagers haven't learned that kind of stuff yet. And so it's hard for them. And I hope people realize that just because I'm talking about this emotional stuff and how pain is processed and the psychology of pain perception doesn't mean that I don't think that these kids have real pain, because they absolutely do. But just like it's wrong to forget about endometriosis and only talk about pain management by um, uh, just like it's not appropriate to only focus on endometriosis and not the emotional things. It's also wrong to focus on the emotional things without focusing on how do we get rid of the disease. So we have to do both. And the reality of life is that disease and pain run in parallel, meaning that you can have really bad disease, and if your pain perception system is set at a fairly high threshold, you may not feel so bad. I mean, yeah, you'll have some pain, but it will be manageable. Whereas if your pain perception threshold is set pretty low, then it doesn't take a lot of disease to make you feel really bad. And that's, I think, the trick and what makes endometriosis be called enigmatic, or, you know, something that we don't understand, because we don't understand the pain processing part of it. So I hope this helps you understand the emotional part of endometriosis, especially in kids. So this is a rabbit hole that I went down when I started researching endometriosis in adolescents. And one of the first studies that I found was this one, which I thought was kind of fascinating. And they studied 180 girls, 18 and younger, who underwent excision of endo. The vast majority of them had stage 1 and 2 disease. a third of them had persistent post-op pain, and 2/3 of them had pain relief at 1 year post-op and had no further pain. And they looked at a bunch of lipid metabolites preoperatively, and they were able to correlate that all of these girls who had persistent pain had the same 19 lipid metabolites that were elevated. So I thought, this is really interesting. What else can I find on this? So then I found this other study looking at chronic pelvic pain after hysterectomy for endometrial cancer. And the metabolites that they found, again, they found a correlation between the women that had persistent pain versus those who didn't in 19 different metabolites, including cholesterol, linoleic acid, certain phospholipids, and triglycerides. And their comment was there is a delicate balance between pro-nociceptive lipoproteins and anti-nociceptive lipoproteins and polyunsaturated fatty acids. Fatty acids can be divided into omega-3 and omega-6, where the first mentioned mainly the omega-3 fatty acids have an anti-nociceptive capacity, and the latter, the omega-6 fatty acids, are pro-nociceptive. And so EPA and DHA are what's called fish oil. They're the main fatty acids in fish oil if you buy capsules of fish oil. And then the omega-6 fatty acids are arachidonic acid and linoleic acid, which is LA, which is the precursor, linoleic acid, arachidonic acid, and then prostaglandins. So I don't know why I found this so fascinating, but I did. And it really makes sense that our diets can help us not have so much chronic pain. So in summary, if you are a parent of a girl with endometriosis, or if you are a young person with endometriosis, these are things that I think can help. Learn resilience and try to be positive, try to adapt to your pain and realize that, yes, I can still function. I can still do the things that I need to do despite having pain. The pain's not going to kill me. And so that positive attitude is going to go a long way. Take omega-3s. So fish oil is helpful. Olive oil is even more helpful because fish oil reduces the nitric oxide and olive oil reduces nitric oxide and oxygen-free radicals, which are inflammatory, and they are also the source of what's called oxidative stress, which causes tissue damage and can lead to malignancies and pain and all sorts of nasty things. So being careful about which fatty acids you eat is really careful. If a teenager has dysmenorrhea, my recommendation is to start on birth control. If it is not tolerated, or if there is persistent pain after 3 to 6 months, then surgery with an expert endometriosis surgeon is appropriate. If I had a teenager, I would not let a general gynecologist operate on them. I would want someone who is familiar with the various visual manifestations of endometriosis, and specifically how endo looks in teenagers, operate on them, because I don't trust that the generalist would know what to do with it. They're not going to excise all the endo. They're not going to excise all the disease. And worse than all that, they may not even recognize it. And so I really, truly believe that teenagers need true experts. and be persistent. The t-shirt that was around a while ago, nevertheless, she persisted, should be given to women with endometriosis, because they have to persist. They have to stand up for themselves, and they have to advocate for themselves. And unfortunately, the world of obstetrics and gynecology is not tuned into women with endometriosis. Yes, there are a few docs here and there who are not true endo experts who are tuned into it, but it is something, it is a disease and a condition that requires people to be their own best advocates. And so I can't tell you how many patients cry in my office when I tell them that they really have disease, because they've been told that they're crazy. They've been told that they have anxiety. They've been told that they've been raped in the past and they don't remember it, and that's why they have pain. They've been told everything under the sun, and it's craziness. They really do have disease, real disease that we can get rid of by doing excision of endometriosis. So if you or a loved one have endometriosis and you want to reach out to us, you can email us at info@pacificendo.net. You can go to the website where there's information on how to become a patient. And we are more than happy to talk to you and kind of walk you through how to get to us and how to help your kids and help yourself. So I hope that this has been educational, and I hope that you've enjoyed it, and have a great day. Thank you. Bye.